Hi, my name is Stephanie Goff. I am a surgical oncologist at the National Cancer Institute in Bethesda, Maryland, and I'd like to thank the Delaware Breast Cancer Coalition for the opportunity to speak to you all during today's breast cancer update. Now, this session is called Oncology Current Approaches, but what you're going to be hearing from me in the next few slides is a future approach that I hope may one day be helpful in treating patients with metastatic breast cancer. Now, certainly all of the work that you're going to hear about, I was assisted by my colleagues in the surgery branch, but none of it would have been possible without the patients that enrolled in our protocols. And so a very heartfelt thank you to them and to their families. Now, I've entitled my talk, The T-Cell in the Tumor, an Experimental Approach to Metastatic Breast Cancer. And so let's take that apart word by word, shall we? So the T-cell in the tumor. What I'm showing you here is an electron micrograph that's been colored. Now, the cell that you see in orange is a cancer cell. It happens to be a melanoma in this case, but the cells that you see attached to it are white cells, white blood cells, or lymphocytes, and a very special kind called T cells. Now, the cells that can find their way to the tumor, like these, we call tumor infiltrating lymphocytes, or sometimes abbreviated TIL. And what we've been able to demonstrate over the course of the last decade or so is that tumor infiltrating lymphocytes can be used as a living drug for patients with metastatic disease. And so how do we do that? Well, it's a complicated schema, but it's actually a fairly simple cycle. So we start with a patient who has a tumor, a metastatic deposit that we can take out in the operating room. We excise that tumor, we bring it into the laboratory, we chop it into small pieces, as few as 6, sometimes as many as 24, and we put those into plates in the laboratory. We then culture those cells over time with high doses of a cytokine that makes the T cells grow and proliferate. And eventually we're left with anywhere from 6 to 24 different cultures of T cells or lymphocytes that we can then test. We can choose the correct ones, what we think are the correct ones, and then give those back to patients. Now we expand those up to the order of 10 to the 10th cells or 10 billion cells. And then we give the patients a little bit of chemotherapy and give those cells back. And when we've done this for patients with metastatic melanoma, we've been able to demonstrate responses in disease throughout the body. So not only here, this young gentleman who has subcutaneous disease, he's got a large nodule here just under the skin of his shoulder. He had multiple other nodules also located under the skin. And just 12 days later, after we've infused these cells, you can see that that tumor has gone away. Similarly, there's a patient here with multiple spots of melanoma in the liver. Those are the darker gray spots that you can see here. And this CT scan was done just prior to therapy. Now, while those tumors did start to go away fairly quickly, showing changes in the CT scan as early as a month after treatment, what I'd like to demonstrate for you is the durability of that response. And I'm showing you a CT scan here from 7 years after treatment, and all that melanoma has gone away. In this third example, what I'd like to show you is that we've got 4 spots of melanoma in the brain. Now, it's often thought that perhaps T cells are too large to cross the blood-brain barrier, and that may still be true, but the presence of the tumor there either disrupts the blood-brain barrier or allows it to become leaky enough that these T cells can get there. And regardless, 3 months after therapy with TIL cells, you can see that these 4 brain deposits are now gone. Now, these were all durable regressions, long-lasting, long-term. And so we wanted to see what that meant outside these 3 anecdotes. Well, when we looked at a group of 226 patients with metastatic melanoma in whom we'd used these tumor-infiltrating lymphocytes, or TIL, as a treatment, we were able to generate a complete response. That means removal of all disease that could be visible in 49 of those patients. Now, if you look at these survival graphs, what these show you is that over time, how many patients that received that treatment were alive. Now, these patients that were on this green line here, those patients in whom we could get a complete response to therapy, you'll notice there are only 2 little step downs. There have only been 2 patients whose melanoma has come back out of those 49. And when you look all told at the patients that were able to achieve a CR, or a complete response, they have a 10-year survival of 96%. Melanoma affects approximately 100,000 people a year, but it's only responsible for about 10,000 deaths a year. And so we wanted to see, could we expand this concept of TIL as a living drug to other cancers? And so we took the same schema and we did a pilot trial of epithelial malignancies. Now, those are the more common you might think of, like colon or breast. But unfortunately, we saw no objective responses. And so we began to think, well, what might it have been about melanoma that was so special? And as it turns out, this was around the time that the TCGA had finished its work sequencing a number of human tumors. And it came out that melanoma was among the most mutated human cancers. We know that the immune system is triggered by things that are not ourselves, so-called self versus non-self. That's what allows our immune system to affect a virus, allows our immune system to go after the bacteria that may be on a splinter that you get in your hand. It's looking for things that are non-self. And it might have been, our hypothesis was that melanoma is so mutated, it might have been those changes in the cancer itself that triggered the immune system. And so we developed a schematic to try to look for those mutations. So while this looks more complicated, in reality, this half of it is everything that we've already talked about. Remove a tumor, chop it into small pieces, grow the cells, test them, and then give them back to the patient. What we have changed now is the target that we use. So for patients with melanoma, we were very often able to create a cancer cell line that we could use as the target for trying to pick which cells we thought might be the best choice for the patient. What we do now is we take that same tumor that we grow the lymphocytes from, we study the DNA and the RNA to look for those very small changes that might lead to a difference in the protein structure of that tumor, something that might make that tumor go from being self to non-self. And we use that information to create a new target to test these T cells against. And we use that information to help us, again, try to choose the best cells. We call these now selected TIL, which we give back to the patient after a little bit of chemotherapy. We have one example of where this sort of selected strategy worked. So this was a patient with bile duct cancer or cholangiocarcinoma. And at first we used our traditional method, being that we took her tumor, grew the cells that grew the best, and gave them to her. And you can see she had a slight decrease in her tumor for a while, but it began to grow back fairly quickly. Well, this was while we were learning about these mutations and how we could find the T cells that reacted against them. And it just so happened that one of those 24 fragments that we grew up for her happened to respond to a mutated form of ERB2IP. And we were able to take that single lymphocyte culture that had grown out. Now remember, 1 out of 24 of those fragment cultures, we developed a treatment for her based solely on that. And she developed and gave it to her as a second treatment. And she developed a durable regression that was long lasting. After about 4 years, we decided to do an operation to take that out. And what we found was that the cells we gave her were still there. They were being blocked by a molecule called PD-1. And so we gave that patient a checkpoint inhibitor, and she's been disease-free ever since. So if we want to explore this in patients with breast cancer, we've got to answer four, in my mind, four fundamental questions. Can we grow tumor-infiltrating lymphocytes from patients with metastatic breast cancer? What does the breast cancer mutation profile look like? The TCGA gave us a good idea of what primary breast cancers look like. We needed to know what the metastatic version of those tumors looked like. Could we identify neoantigen reactivity? Could we find those T cells that were able to react against changes in a patient's tumor? And then finally, can we use that information to treat patients? And so step one, TIL can be successfully grown from breast cancer metastases. What I'm showing you here is data from 42 patients from whom we resected tumors. And in each of them, we were able to grow T cells. You can see it's mostly a T cell product, that's 90%. But then the breakdown of that T cell product was slightly more of those cells were helper cells or CD4 cells, and fewer of them were killer cells, traditional killer cells or CD8. There's a little bit of a difference from our patients with melanoma, who also had a primarily CD3 product, but are heavily more favored toward the killer cells versus the helper cells. Now, what we found when doing this was that there was a large variety of cultures across our patient population. And you can see just from the differences in the visual plot that you've got here, some had fewer CD4, some had more CD4, some had fewer CD3. Now, not only was this a difference across all the patients that we treated, if you were to look at one individual patient, each of those 24 fragments could have a different makeup. So what was really intriguing is that taking a single tumor from a single patient, just chopping it up into 24 random pieces, you could get different lymphocyte populations that would grow out. It gave us a huge variety of lymphocytes to be able to test against these mutations. Speaking of mutations, what is the mutation profile of a resected breast cancer metastasis? Well, we found that there were a median of 112 mutations per patient, but there were no correlation between the number of mutations and either the patient's age, the receptor status of the tumor that we took out, the number of prior treatments, including chemotherapy and hormone therapy, or the site of resection. There was some concern that perhaps a tumor clone that was able to go to the liver might have a different mutation profile than one that was able to go to the lung or one that was just able to go to the lymph node. But it turns out that those mutation profiles were fairly similar. The next and probably most complex step, certainly the one that required the most work, was trying to understand if we could identify neoantigen reactivity. Now, again, as a reminder, we try to make this target using the patient's mutations, and then we study those lymphocytes that we've grown. Now, we knew from studying a large number of patients with melanoma and with gastrointestinal cancers that very few of the mutations that we tested would actually turn out to be immunogenic. Now, we do this using functional co-culture, putting tumor and T cell in the same dish in the same experiment. Many times people will call things neoantigens. They are based on computerized predictions. We like to do the functional studies so that we know that there is a T cell in that patient's body that knows how to see that mutation. And so we proceeded to start to study these 42 patients. Now, the first time that we were able to do this was back in 2014, 2015, and we eventually published that in 2017. So there's been a lot of work that's happened in the last 5 years. But just to show you an example of what one of those would look like, this is our first patient in whom we were able to find reactivity. The upper graph is showing interferon gamma, which is a cytokine that's released when a T cell sees its target. It's something that's released by the cell. And the second graph that you're seeing here is a surface marker on the cell. When a T cell gets activated by its target, it will put this marker up on the surface, and it can be seen using techniques that we have called flow and flow cytometry. And so what we're looking at here is that each of the 24 different fragments that this patient had, we tested them against combinations of the mutations that we had identified for her. Now, she had 72 or so different mutations, and we split those up into pools that had about 12 each. And this one that you see boxed here means that the lymphocytes that grew out of the 9th piece of tumor that we cut, or fragment 9, reacted against one of the peptides that was in the 3rd pool that we put together. Not only did it secrete interferon, but it upregulated 4-1BB. And we do these in concert just so we can have some correlation between the two. So the next step, though, is to find out what is it in pool 3 that those T cells might be reacting to. And so we then look at each of the different mutated peptides that were in that pool, and you can see from the single elevated bar graph here that it was mutated RBPJ. The results that you see over here in graph form are seen here in their primary data. This is what we call a FACS plot, and it's showing you T cells that are either CD4 on this side or CD8 on this side, and then you're seeing upregulation of these activation markers. One is called 4-1BB, another is called OX40. When you put the cells in contact with the mutated version of the peptide, you see this cloud of cells that exist here. Each dot here is a T cell, 38% of them were upregulating 4-1BB, and 52% of the cells that were CD4 also upregulated 4-1BB. So this is a nice correlation to go with the peptide product that we had found. Now, you can imagine for this one patient, this was over 150 different individual culture dishes together. We did this now for 42 patients. And what we found was that neoantigen reactivity exists in the majority of patients. So 67%, or 28 of the 42 patients that we studied, had tumors that contained immunogenic mutations. And on average, that was 3 neoantigens per patient when we could find them. And so you can see here, the median is 3. And when you look at the different clinical markers, so hormone receptor positive, while there are some patients that have neoantigens, less than half of them did. And the triple negative and HER2 enriched, you can see those patients there. What we found was that, again, the hormone receptor positive patients were less likely to develop immunogenicity within their tumors. However, triple negative breast cancer and HER2 positive enriched disease had a slightly higher hit rate when it came to finding immunogenic reactivity. There was no difference between BRCA patients that did and did not have known deleterious BRCA mutations. All told, we studied over 4,000 different mutations in these patients, and only 2.3% of them were immunogenic. Now, one interesting thing that came out, and this again has been clarified in both melanoma and in gastrointestinal cancer, is that the neoantigens are unique. In fact, in the close to 200 patients that we've studied, there's only been one single instance where the actual mutation and the immunogenic molecule that's required to engage that were the same. And that was in 2 patients with colorectal cancer. In this study of 42 patients with breast cancer, every single recognition was unique. Now, while there were 3 patients that had TP53 mutations, a common oncogene, they were mutated at different positions within that gene, and they were recognized by different immune elements. For some of these patients, we were actually able to take the next step, which is the one that's probably more clinically relevant to many of you, and that is we were able to treat 6 of these patients. Now, TIL is treatment for metastatic breast cancer. It is a slightly complex inpatient routine. So if you think about the day that the patient gets their cells as day 0, we start chemotherapy a week prior. These patients get 2 days of cyclophosphamide and fludarabine, followed by 3 additional days of fludarabine. The reason for that is to sort of just wipe out the immune system that the patient has, to give these new cells plenty of room to grow, plenty of room to proliferate, and to create a lot of the rich cytokines that the body needs to support those lymphocytes. We also give a dose of what we call adjunct pembrolizumab. And that's because we know that these TIL cells have the likelihood of have a marker upregulated that's called PD-1. Now, when the body sees PD-1, it tries to shut a T cell off. It's just a natural mechanism that our body has evolved over years to have. But we don't want these cells being shut off. So we use pembrolizumab, which is an anti-PD-1 therapy, to try to prevent these cells from being shut down. We also deliver interleukin-2 intravenously. This is, again, to support those cells. They've been living in interleukin-2 for about 3.5 weeks at this point. And so as they make that transition from plastic back into a person, the IL-2 can help them flourish and proliferate. You can see here we did treat 6 women with this treatment, and we've had 3 objective responses, 1 complete response and 2 partial responses. Now, many of you are likely familiar with the patient that developed a complete response. We reported this in 2018. So if we want to take step by step, go through her treatment cycle, this is the experiment that I've described to you before. What you're seeing here is the actual well, or actually an image taken after an evaluation to look for interferon gamma. So each dark spot that you see here is a T cell that's expressing interferon gamma. So when we exposed these 4 lymphocyte cultures, and again, these just happen to be randomly the 5th, 8th, 12th, and 13th fragment that we cut out of a single tumor, they responded to peptide pool 1, peptide pool 6, and they did not respond to peptide pool 4. So you can see where we've got them highlighted. These were the ones that we considered positive. Now, a good reminder that these are a living drug. When we tried to grow these up to the billions to try to give back to this woman, F5 didn't want to grow. And so we developed an infusion product for her that included fragment 8, fragment 12, and fragment 13. Now, when we administered this product, she had large disease. You can see this substernal nodule as well as 5 spots here in the liver. This first image that I'm showing you is at 14 months, but I'm happy to report that we now have imaging beyond 5 years, and she remains disease-free with no additional therapy for her metastatic breast cancer. We also had 2 partial responses. Now, one of these was in a patient who has triple-negative breast cancer, and you can see she had a large tumor in the breast. She had not undergone a mastectomy because of the size of her disease and the cutaneous involvement of the skin, as well as some lymph nodes. And you can see over the course of treatment, that tumor started to get smaller. What you're not seeing here is another image at 6 months that was much unchanged from 4 months. At 10 months, what we saw was a dramatic reduction in the breast disease. However, her axillary lymph nodes had started to grow. We made the decision at this point to render her surgically NED. We did a mastectomy and lymph node dissection, and she received some radiation after that. But I'm happy to report 2 years later, she remains disease-free. We had another patient with HER2 positive breast cancer for whom we did this same strategy. You can see at baseline, she had cutaneous disease. It worsened somewhat as we were going through treatment and then started to regress. You can see a surgical scar here. We did resect a small nodule to try to understand what was happening to this response. And then unfortunately, about 1.5 years later, she developed a new lesion that had recurred in the same area as her prior disease. We resected this, and now 1.5 years later, she remains disease-free. But the fact that this disease was cutaneous gave us the opportunity to study some of the tumors, some of the cells that we had given her. And so one of the ways that we could do that was by tracking the cells that we gave her, because each T cell that we have in our body has a unique molecular coding called a CDR3 region. And by using that, we can track families of cells as they come and go in a patient's blood population. Now, what we knew was that when we first saw this young woman and resected her tumor to prepare for treatment, she did have some neoantigen reactivity in her blood at the level of about 1% or 1 in 100. In her blood, though, at the very same time, those same cells that were present in the tissue of her tumor were twofold less, so about 1 in 100,000, 1 in 10,000. However, you can see when we gave her a treatment that was pretty highly enriched, and she carried those T cells for a while, over time, they reduced down to about 0.1%, or 1 in 1,000. And despite these cells existing and being present in the tumor, it wasn't enough to stop this tumor coming back. So we obviously have a lot of things to learn and a lot of avenues to explore as we move forward. So what is the next generation of cell therapy? Well, like I just spoke to you about before, we can investigate the TIL that we give to identify T cell receptors. So when we do these studies and we place these T cells in touch with their target, and we see that upregulation, those dots that are expressing 4-1BB, you can actually pull those cells off to the side and study them intently on their own, and you're able to identify the genetic information that encodes this alpha and beta receptor. When we did that, we identified 129 TCRs that recognize 68 different neoantigens. Now, for some of these neoantigens, they would only generate a single TCR within a patient's blood. Some of them appeared to attract a wide range of T cells, having as many as 8 TCRs for a single neoantigen. We can use that information when we find it against shared things like TP53 or KRAS to then create a way of genetically engineering patients' T cells into something we call iTCR or individualized TCR. We can actually put a second TCR into a patient's blood and provide a cell treatment for them that doesn't require an operation. And that's really the next wave that we're looking for, not only for patients with breast cancer, but patients with other cancers. So talking about the T cell in the tumor, this experimental approach to metastatic breast cancer. Can we grow TIL? TIL were generated from every single patient that we studied. What does the mutation profile look like? It is unique to each patient. There are about 100 mutations per patient. Can we identify neoantigen reactivity? In most of the patients, 67% of them, we were able to find it. Can we identify TIL to explore treatment in patients? We have demonstrated the possibility of response, but we do not know what is more likely to make that response happen. And that's what we need to work on now. The first step is always demonstrating that something is possible, and the next step is working to understand how and why so that you can improve the chances of the patients on your protocol. In addition, we can extract that TCR information so that we can build future experimental protocols with genetic engineering. So how do we do this? Well, we run all of our clinical trials at the surgery branch in Bethesda. This is our referral email here. It stands for Immunotherapy Referral Center, and that goes directly to a team of referral nurses that I work with on a daily basis. And what sort of patients are we looking for? Well, the ideal candidate has metastatic disease without a potentially curable option, an excellent performance status, and no brain metastases. And what am I looking for when I review a chart? Are there any contraindications to high-dose IL-2 or checkpoint blockade? Is there a tumor that we can resect with minimal risk to the woman or man involved? And is there a tumor that we can follow for response? We then coordinate that care with home oncologists and local surgeons. It does take us about 3 to 4 months sometimes to do this neoantigen screening that we discussed. And sometimes after a patient's gone through TIL therapy, we again will work with local oncologists and home surgeons to provide support for blood work and other things after that. As you might imagine, we have a presence on the internet, and you can find us here. You can Google me, and it will also take you to this page. It has some answers and some questions and some information for anybody that might be interested in our clinical trials. And I just want to thank again the Delaware Breast Cancer Coalition for this opportunity. And I look forward to answering any of your questions. Thank you.